So, so especially for this surveillance part, so that high risk based surveillance system we had and things. So how it supported this malaria elimination?
Yeah. So in the new global strategy for malaria from 2016 to 2030, surveillance spaces should be a intervention by itself, because it's very important. And what it does is, it not only tells you where the infection is, it tells you where to respond.
Where to respond also.
Yeah. So that is very important. And then right now we follow a 125 or 137 model, where notification is immediate, then investigation within 2 or 3 days, and response within 5 to 7 days.
5 to 7. So 1, 2, 3, 1, 5, 7.
Yeah, I think it's 1, 2, 5 or 1, 3, 7. 137 was the earlier
strategy used. So 135 and investigate and action within 7 days, like that.
So that way you make sure that there is no
spread. Okay.
And then the action includes things like vector control, malaria distribution, screening people around the residents. So all that
active surveillance for the active surveillance is also key for this malaria control, I think. So we adapted things. So you said mobile malaria clinics also they did.
Now they don't do.
They don't do that. Yeah.
So now there is something called a case review committee, where each and every case is reviewed by this case review committee, and then the case is classified, whether it's an imported case, introduced case, induced case. So since elimination, we have had one introduced case, that means there was local
transmission.
One induced case, blood transfusion, blood transfusion. The blood transfusion was from a armed forces personnel who had served in peacekeeping mission.
Peacekeeping missions, yes.
And then came and donated blood to a thalassemia patient.
Oh.
And then
it is in Kurnavala.
Correct. And then there we also had 2 deaths.
2 deaths.
23 and 24.
24.
So the main objective of the anti-malaria campaign is not only to prevent the establishment of malaria, but also to prevent malaria deaths. And we analyzed some data, and it was revealed that the time taken for the patient to visit the healthcare
facilities
personnel is less than the time taken for a doctor to diagnose malaria.
Very quick to.
Patients do better than doctors.
So quick to come to doctor, but doctor take times. There's another question also I have on that. I think nowadays people don't have that experience of this malaria clinical symptoms and things. We have that health workforce awareness on this diagnosing or the vigilance of this. So from health system strengthening perspectives, how important is sustaining this professional awareness and diagnostic vigilance in a malaria-free country? So what institution mechanisms that need to prevent such problems?
So that is very important. Now there are certain things that the AMC does. One is it has assessment and training of microscopists. You see how well their diagnosis is. Obviously, you see thousands and thousands of slides without seeing a positive case. So there is a continuous training program that takes place. There is also accreditation process called ECAN, it is External Competency Assessment of Microscopists. It is done in collaboration with WHO and ACMAN, and there they sort of grade the microscopies into different levels. So that is being done. When all positive cases are confirmed by the reference laboratory at the
AMC Colombo.
Yeah, and 10% of the negative sites are also cross-checked.
Okay, cross-check.
The clinicians, they have regular programs through their medical associations and all that. So doctors from AMC go and conduct these programs. There is a WhatsApp messaging system.
SMS also, I think.
Yes. And also, where doctors have diagnosed correctly, they are sent a letter of appreciation.
Appreciation. Okay.
Those who have missed the diagnosis also, they are told that they have missed the
Diagnosis.
So those things keep working, and it's difficult to maintain the vigilance, but they'll have to do it as long as malaria is prevalent in the world.
So it will go for years and years. I think this Africa still is an endemic, even epidemic for malaria. So anyway, we have to keep this vigilance for it's years and years, because we have the vectors here.
Yes.
Where the global traveling is there. So
now coming to speak of vectors, the interesting thing is 3 months after we got certification, malaria-free certification in 2016 September, in 2016 December, we detected a new vector in
in
Mana, and then
Jaffna.
Jaffna, still a problem in Jaffna, and Kalmune. So now that is an urban vector, and it's a very invasive vector. It has spread across the world.
Yeah, that's the thing. Another thing I have this for this entomological surveillance and how this changed their receptivity. So
it's very dangerous, because we have never had urban malaria in Sri Lanka.
Majority of cases are from rural areas, not from the urban areas.
So with this urban vector, we are in
urban vector means breeding places.
Like water tanks.
Anything possible. Usually Anopheles Culicyphasis need only pure water, that ponds and things. Rivers and
streams and all that.
But this is Stephensi.
But I must say, the Vaunia has eliminated. Vaunia Mana also, and how? By using larvivorous fish. The Anopheles stevensi is resistant to insecticides.
So current using insecticides are not working for Stephensi.
So just by putting these larvivorous fish into the wells, they were able to get rid of them.
Right.
So I think that's a big achievement, and
so we need to keep this vector surveillance more and regularly, and because it should be a pockets, I think, not all of the places until now, I think so.
We were also very fortunate. Now, if you look at the importation risk of malaria in Sri Lanka, most of the travelers are from the western province. They are the
movers, frequently moving.
So for our luck, the vectors are not there in the western
province.
So we are fortunate. But only thing is, with the tourists going to the dry zone, we don't know.
We don't know the things,
So those are the issues.
I think that's good. I think you pointed now also just good for us also. Now we are opening the international airport in Palali, so that will make more ferry services. So more people frequently moving in the north. The vectors are more in abundance. So high chance. So then the immigration people or something to monitor more in that aspects. We have to look.
Yeah, that's very important. And also to get the patients to give a history, a travel history. And sometimes there are illegal migrants who don't want to reveal it.
To read it, yeah.
So that's also a problem. So these are some of the issues we have.
Okay. So there's a possibility for reintroduction of malaria. We have anyway.
Now there is a distinction between reintroduction and re-establishment. Re-establishment of malaria, because unlike in other diseases, we have eliminated indigenous transmission. So for re-establishment, you have to have evidence of infection, indigenous transmission for 3 years.
2 years.
Of the same species,
okay,
in the same locality, right?
Generally, they will say, the will say it's re-established malaria in the country.
Yeah, so you have to have evidence of indigenous transmission for 3
years.
The same
locality, same species. Yeah.
So re-establishment is difficult.
With our other scrutiny, surveillance and systems we have, that's difficulty.
But reintroduction, you can get a new.
Yeah.
But that
just a one go, come and go like that, I think so. So
it won't be
re-establishment won't be.
Because if there is re-establishment, we run the risk of losing malaria-free
states. That's what I think we need the campaign strengthening. We need to strengthen the campaign. We can't, no cases, we can't say no need for the campaign. We need to strengthen it because to prevent this re-establishment, we need a strong campaign. So, definitely, we need that. So the multi-sector collaboration. So you already mentioned about the Triforces, are one of the things. Other multi-sectors who are partnered with us.
Okay, so one is that, then the other thing are the travel agents. These people who organize pilgrimages, safaris.
Safaris, okay.
Then we also, AMC also has established relations with Umasuthasarma.
They're going for Buddha Gaya and other places.
Then the armed forces.
Mm-hmm.
Then there are pockets of gem merchants.
Gem agents, yeah.
Yeah, from Birul and all. They are frequent travelers to Africa, Tanzania, Mozambique, on this gem trading.
Gem trading, okay.
So they have established links. And then with all the even clinician GPs and all.
And development project planners or these people who are doing development mining. So this make.
Yeah. Although now it's not that much because there is no indigenous transport.
And you got, I think, more support from the immigration authorities, I think, in relation to imported malaria.
We got support during the COVID-19.
For the COVID-19, not for...
Because during the COVID-19, when the people were brought back to Sri Lanka, the immigration people informed the AMC that these people are coming from malaria endemic countries. So all of them were screened. Malaria also. Yeah.
In the indirect outcome of it, I think so. Even though we targeted for COVID-19, but indirectly.
Yeah. So on the 10th day or something, when they used to do the testing, then they used to test for malaria.
You got that doses, okay, yeah, they're coming and...
yeah.
So, okay. So GFA team's role you have explained well, I think, since 2001 onwards.
And GFA team funded us even after we eliminated malaria for 2 cycles, which they are not doing for other countries.
Other countries. Other success stories, I think.
So their funding went up to 21.
21 up to.
So that was very helpful to the AMC too, because they have to have a financial transition plus
definitely technical transitions. Yeah. Can you explain more about the WHO's contribution for this elimination, sir?
WHO gave all the
Technical advices and things.
and they supported us in key areas like they helped us with external reviews. Even the pre-certification review, they organized it. So that was their major contribution.
Okay. So this is the malaria elimination as a policy model. So from a public health policy standpoint, how should Sri Lanka adapt a policy or need to adapt the policy reformations for malaria elimination is there? So do we need anything else more
I'd
that?
like to say now that we have eliminated for prevention of re-establishment.
Re-establishment.
Now I think countries which are eliminating malaria or are in the prevention of re-establishment phase, malaria is a health security problem. It's no longer, it's like cholera.
Yeah.
So we should now move into move as part of the international health regulations.
Yeah, it's a security, international travel security like it. I think we should.
Correct. Especially for the countries which are eliminating malaria or which are in the prevention of re-establishment. So I feel that the next policy
Should be there. I think when we are giving the visas, we have to for certain things.
not only visas, but in case there is a case detected, then we should inform all the other countries around that.
Okay, it's like the group A diseases like yes, plague, yellow fever, like cholera, like I think this also to be incorporated into that part. So WHO have to work on that because more countries now, I think
because more and more countries
these are now eliminating and the vaccines are going to be introduced in Africa.
Among children, but
yeah. No, that in future definitely it will go, I think so.
So the only other threat is this funding. US government has stopped funding. They pulled out a WHO. Very sad.
So that will be the initiatives in Africa for malaria is going down. So that is a threat for us also, indirectly having the malaria, the country.
It's very sad that the WHO has withdrawn from that.
Yeah.
The US government has withdrawn.
Yeah. So, based on the experience to control or eliminate this malaria in the country, so what is the advice for other communicable diseases? Any initiatives we can innovatively move forward for maybe dengue or leptospira?
Yeah, one thing is good public health practice, right? Second thing is I think we have to go beyond like for example what the Global Fund did was funding different positions, surveillance of
we have to identify the different people needed to key people,
key personnel. And then we also have to ensure that there is sufficient funding and resources. Because right now everything is curtailed, including human resources.
So it's a main threat for us to continue these diseases. Okay. Okay, sir. Well, thank you so much for your valuable time and your experience, and I think hopefully it will be a very good resource, a very valuable resource for us and for future generations for keeping these memories and the experiences. We can't get it in the books anywhere. So these are things to be documented and to be transmitted or transferred to the next generations. That's the main purpose of this podcasting series, to approaching through new channels. Writing books is not suitable for the current generation. So that's why we initiated this innovation. So this thing will be more successful. Thank you so much, sir.
Thank you, Dinesh.
Okay.